The next topic is movement disorder emergencies. We know it's a very important topic because sometimes it's very difficult to diagnose and manage. And I would like to introduce Dr. Thuong. He is from Medical Center of Ho Chi Minh City. And Dr. Thuong will present this topic. And Dr. Thuong, yeah.
Thank you for the introduction. Good morning, everyone. I am Thuong Dang. I am working as neurologist at University Medical Center of Ho Chi Minh City. Today, I would like to talk about movement disorders emergency. As you know, movement disorders are gradually progressive and do not require emergent intervention. However, there are many situations in which movement disorder present with an acute severe phenotype. And a movement disorder emergency has been defined as any neurological disorder involving acutely or subacutely over hours to days, in which clinical presentation is dominated by movement disorder. And delay in diagnosis and treatment may result in significant morbidity or even mortality. Movement disorder emergency can be divided into six main topics as following: emergency in Parkinson's disease, acute drug reaction, acute exacerbation of chronic movement disorder, acute career and myoclonus, Serotonin Syndrome, and malignant catatonia. Let's begin with emergency in Parkinson's disease. Emergency in Parkinson's disease includes severe motor fluctuation, dyskinesia, hyperpraxia syndrome, acute psychosis in Parkinson's disease, acute Parkinsonism, and Parkinsonism hyperpraxia. Motor fluctuation in Parkinson's disease typically are not severe enough to require urgent intervention. However, some patients may present extremely rheumatic periods, especially when they occur suddenly. Symptoms include ruminant, akinesia, dysautonomia, psychiatric features, such as anxiety and panic. In this instance, history taking should look for potential triggers, including infection, dopaminergic medication chain, and anti-dopaminergic drugs. Management involves various combined approaches, such as fragmentation of daily dose of levodopa, correct levodopa tablets, control release or reversible levodopa, and subcutaneous dopamine agonist, MABs, and COMT inhibitor, and deep brain stimulation. The patient has been diagnosed as Parkinson's disease for 10 years. She has severe periods. Moving to dyskinesia hyperpraxia syndrome. Dyskinesia hyperpraxia syndrome consists of severe dyskinesia leading to rhabdomyolysis, dehydration, hyperthermia, and confusion. Generalized dyskinesia may be complicated with involvement of preparatory posture. Patients may report diphtheria, tachypnea, and chest wall discomfort. Treatment includes lowering or holding levodopa dosage, maintenance, or DBF. The patient has been diagnosed as Parkinson's disease for 16 years. She has severe peak down dyskinesia. Moving to acute psychosis in Parkinson's disease. Acute psychosis in Parkinson's disease is a common reason for inpatient admission and strong predictor of nursing home placement. The manifestation typically includes visual hallucination, auditory hallucination, delusion, and confusion. We had to look potential triggers including metabolic derangement, infection, and change in drug therapy. After treatment of potential comorbidities, a stepwise withdrawal of potential contributing agent is recommended. start with anticholinergics, followed by cyclists, MAO-B inhibitors, amantadines, other antidepressants, dopamine agonists, COMT inhibitor, and apomorphine, and the last, levodopa. Psychosis in Parkinson's disease can be treated with clozapine, pimavanserin, and quetiapine. Acute Parkinsonism comes more frequently caused by exposure to dopamine receptor blockers, such as neuroleptics or anti-emetic. Other causes include intoxication, structural brain lesion, infection, and neuropsychiatric syndrome. A child of levodopa to Turkish, akinesia, and rigidity is recommended. Once the primary pathology is managed and symptoms improve, dopaminergic therapy can be gradually switched up. This is a case with severe acute Parkinsonism associated with streptococcal infection and antibasal ganglion antibody. The patient presents with a severe acute akinetic and rigid disorder 2 weeks after completely recovery from an episode of pharyngitis. Neurological examination reveals symmetrical akinetic citrus syndrome, which reduced facial expression, severe hypophonia, rolling of the liver, and tremor of jaw, tongue, and both hands. Magnetic resonance imaging of the brain reveal abnormal high signal intensity of basal ganglia on G waves. His symptoms improved with intravenous methylprednisolone and immunoglobulin. The 60-year-old male patient was admitted local hospital with nausea and vomiting. The blood test showed severe hyponatremia. 2 weeks after admission, he presented bradycardia and rigidity. MRI revealed hyperintensity of the basal ganglia on flare. And he was diagnosed as acute Parkinsonism caused by extrapontine myelinolysis. Let's talk about Parkinsonism hyperparaxia. Parkinsonism hyperparaxia mimics neuroleptic malignant syndrome, but it occurs after rapidly withdrawing or reducing dopaminergic therapies or suddenly stopping DPS. It is characterized by severe rigidity, hypothermia, agitation, and mental status change, dysautonomia, and elevated serum creatine kinase level. Treatment includes supportive care, reinstitution of premorbid dopaminergic drug therapies, and occasionally dantrolene is necessary. Another topic about acute drug reaction. Acute drug reaction include acute dystonia, neuroleptic malignant syndrome, serotoninergic syndrome, and malignant hyperthermia. Acute dystonia typically develop within 24 hours of starting the drug. Symptoms include blepharoplasm, toxicosis, laryngeal dystonia, gismut, and oculoglycic crisis. Laryngeal and pharyngeal dystonic reaction may play as risk of imminent respiratory arrest. Risk factor of acute dystonia includes younger age, male gender, or previous histories of similar reaction, recent use of cocaine and commodities with mood disorder and metabolic abnormality. Acute dystonia is usually self-limiting and reverse rapidly. Medication can cause acute dystonia, including antipsychotics, antidepressants, antiemetics, fluoroquinolones, and antiepileptics. Acute dystonia can be managed with intramuscular or intravenous anticholinergics or antihistamine. A 22-year-old male patient has oculocytic crisis induced by methylobromide. His symptoms improve with intramuscular diphenhydramine. Moving to neuroleptic malignant syndrome. The syndrome occurs in patients taking dopamine receptor antagonists. It can occur anytime during antipsychotic therapies. It typically presents within 4 weeks of exposure of antipsychotics. A majority of cases develop within 7 to 10 days. Risk factors include abrupt dose escalation, epilepsy, and SSRIs, fever, dehydration, exhaustion, extrapyramidal syndrome, and previous neuroleptic malignant syndrome episodes. It is characterized by mental status change, rigidity, hyperthermia, and dysautonomia. The wide variety of medication can result in neuroleptic malignant syndrome, including neuroleptic agent and antiemetic agent. Multiple laboratory abnormalities may be found. Serum creatine kinase elevation reflects rhabdomyolysis, and it typically more than 1,000 IU per liter. Based on the DSM-5, all major criteria and at least 2 other criteria are required to diagnose neuroleptic malignant syndrome. Major criteria include exposure to dopamine blocker, severe muscle rigidity, and hyperthermia. When the patient has neuroleptic malignant syndrome, the first step is to stop dopamine blocker. Supporting care includes cooling measures, volume replacement, and correcting electrolyte acid-base imbalance. Complications such as thromboembolism, rhabdomyolysis, and respiratory pneumonias must be prevented. Benzodiazepines can be used in patients with catatonia, mutism, and agitation. Bromocriptine and amantadines can be used to target dopaminergic pathway, and dantrolene can have rhabdomyolysis and hyperthermia secondary to muscular rigidity. Electroconvulsive therapy has been found to be effective in some patients with severe neuroleptic malignant syndrome. Let's talk about serotonin syndrome. A recent addition or increase in unknown serotonergic agents that may cause serotonin syndrome. Serotonin syndrome typically results from the combination of 2 or more drugs that enhance serotonergic transmission. Symptoms include change in mental status, agitation, myoclonus, hyperreflexia, diaphoresis, shivering tremor, diarrhea, and incoordination and fever. This established medication just can cause serotonin syndrome. The Hunter serotonin toxicity criteria were developed in 2003. Serotonin syndrome are diagnosed at the presence of more common clinical features. Treatment of serotonin syndrome begins with immediately discontinuation of all serotonergic agents. My symptoms can be managed with oral benzodiazepine. And patients who are more used may require more aggressive treatment, including cooling measures, intravenous fluids, intravenous benzodiazepines, and the use of serotonin antagonists. Dantrolene can be used in patients with severe symptoms. These tables have to distinguish neuroleptic malignant syndrome, Parkinsonism hyperplasia syndrome, and serotonin syndrome. Medication history is very helpful because serotonergic agent can cause serotonin syndrome, while dopamine blocker cause neuroleptic malignant syndrome, and withdrawal of dopaminergic cause Parkinsonism hyperplasia. Serotonin syndrome typically develops within 24 hours of starting or changing therapy, while neuroleptic malignant syndrome symptoms can be present for days to weeks. Serotonin syndrome produces neuromuscular hyperactivity such as clonus and hyperreflexia, while neuroleptic malignant syndrome is characterized by more sluggish responses. Malignant hyperthermia occurs when a patient with an inherited malignant hyperthermia susceptible mutation is exposed to trigger anesthetic agent. It's rapidly onset of hyperthermia, fluctuation in blood pressure, hypercapnia, hyperkalemia, metabolic acidosis, muscle rigidity, and rhabdomyolysis. Treatment with dantrolene is effective, combined with the discontinuation of the trigger agent, correction of metabolic and electrolyte abnormality. Let's move to another topic, acute exacerbation of chronic movement disorder. Acute exacerbation of chronic movement disorders include dystonic storm, laryngeal dystonia in multiple system atrophy, and other conditions, tick status, and Wilson disease emergency. Dystonic storm is a rare state of generalized unremitting severe dystonic spasm. It's usually developed gradually after weeks or months in people with pre-existing generalized dystonia. Potential triggers include medication exertion or withdrawal, infection, hyperthermia, dehydration, trauma, or penicillin therapy with patients with Parkinson's disease. Certain muscle spasm may lead to hyperplasia, dehydration, rhabdomyolysis, renal failure, aspiration, pneumonia, respiratory failure, or multi-organ failure. Treatment include anticholinergics, dopamine receptor antagonist, dopamine deleter, clonidine, clonazepam, baclofen, and deep brain stimulation. This patient was diagnosed with Wilson disease, and her symptoms didn't improve with the penicillin. She has generalized dystonia. Let's start with the laryngeal dystonia in multiple system atrophy and other conditions. Laryngeal dystonia may provoke acute airway obstruction and stridor. It's usually developed as a reaction to neuroleptic or can complicate multiple system atrophy or generalized multifocal dystonia. Laryngeal dystonia can be managed with continuous positive airway pressure, adductor muscle botulinum toxin injection, Walker cordotomy, or tracheotomy. This patient was diagnosed at multiple system atrophy. She presented with stridor all day, and she was managed with tracheotomy. Patients with this may develop unremitting cell insurrectics that cannot voluntarily be suppressed. Treatment for the status include typical neuroleptic, dopamine deleter, mood stabilizer, botulinum toxin for focusing and deep brain stimulation. This is occurred with cervical myelopathy secondary to Tourette syndrome and managed by organ deep brain stimulation.
Can I get you to try and tone it down for 10 seconds? See if we can do that. Yeah, I'm going to count to 10. I'll do that ready, steady, go, and then let you do it. Stop it for 10 seconds. Okay. Ready, steady, go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, that's fine. Okay. Okay then.
This is another patient with severe tic. Moving to Wilson disease emergencies. Wilson disease is an autosomal recessive disease of copper metabolism caused by mutation in the ATP7 gene. The most common neurologic symptoms of Wilson disease are tremor, dystonia, ataxia, and Parkinsonism. Emergencies in Wilson disease are related to sudden worsening of neurological symptoms, particularly after use of the penicillamine. This patient has severe Laryngeal Dystonia. Career may present acutely in the several settings. The differential diagnosis include drug or toxin exposure, metabolic derangement, vascular disease, infectious, post-infectious etiologies, molestation, and autoimmune condition. Symptomatic therapies include dopamine receptor blocking agent, tetrabenazine, deutetrabenazine, and the prognosis varies according to the etiology. The patient was admitted our hospital because of hemichorias on the right side. And they were diagnosed as the acute hemichorianism caused by hyperglycemia. The next one is the Myoclonus. Myoclonus can present emergently. Metabolic toxin, drug-induced encephalopathy, and post-anoxic state following cardiac arrest may produce a state of generalized myoclonus. Cerebral anoxia may cause two syndromes, include post-anoxic myoclonus and myoclonic status epilepticus. Myoclonic status epilepticus usually indicates poor prognosis and begin with in out of the anoxic event. And post-anoxic myoclonus can be managed with clonazepam, valproate, and levetiracetam. This patient had post-anoxic myoclonus. Moving to sleep person syndrome. Sleep person syndrome is a rare neurological disorder characterized by the presence of fluctuating muscle rigidity and spasm of the trunk and more proximal body parts. The spasm often associated with intensive pain and typically begin with an eruption followed by tonic activity. Cause of sleep person syndrome include diabetes mellitus, Graves' disease, Hashimoto's thyroiditis, pernicious anemia, and paraneoplastic syndrome. The management of sleep person syndrome is based on the use of drugs that promote GABAergic inhibition, for example, benzodiazepines and baclofen. Variable degree of benefits have been reported with the use of anti-epileptic drugs. Malignant catatonia is a neuropsychiatric syndrome with a phenotype resembling neuroleptic malignant syndrome, but no histories of dopamine receptor antagonic exposure. Symptoms of malignant catatonia include fever, rigidity, catatonia, and behavioral disturbance and dysautonomia. The condition often occurs in the context of psychiatric disturbance, but may also occur secondary to drug intoxication, metabolic disturbances, illness, encephalopathy, head trauma, and MNDA encephalitis. Patients with malignant catatonia can be treated with benzodiazepines and electroconvulsive therapies. Can have patients with psychiatric cause. In conclusion, movement disorder emergency include hyperkinetic or hypokinetic presentation. And movement disorder emergency need to be accurately diagnosed and properly managed to reduce morbidity and mortality. Thank you for your attention.
Thank you, Dr. Thuong from University Medical Center for the talks. We have a time for only one questions. Any question in this room?
I have one question to ask you. Which medication should we start in Wilson disease? Because as you said, the penicillin can worsen the severity. So should we start with the penicillin in Wilson disease? Thank you.
Thank you for the question. Patients with Wilson disease must be treated with chelator agent. And the main drugs includes GNT and penicillin. GNT may be preferred to treat patients with severe neurological disorder because many article reports the penicillin can but patient just were treated with penicillin can has worsen neurological symptom. But now in Vietnam, GNT is not available. So it is important we should begin drug with the low dose and monitor blood test and urinary. Dr. Tyson had many experience in this patient with Wilson disease. Yet Dr. Tyson could give some comment about drugs we should choose in patients with Wilson disease.
Dr. Thuong, now actually our patient can afford Trentin now. Yeah, in Ho Chi Minh City. Yeah.
Just some minute, Doctor.
Yes, thank you. I also treat some patients with Wilson disease. They have neurological symptoms, but I see in my experience when we use the penicillin at the beginning, the patient around 30 to 40% of the patient have the symptom worsen, especially the patient with dystonia. But the patient with tremor and they better. So in the patient with the Wilson disease patient with Dystonin syndrome, I usually begin or the penicillin with a very low dose and slow increase, or sometimes I'm changed to use zinc in some case. That's in my opinion about treatment of Wilson disease. Thank you.
Thank you very much. Thank you very much for two speakers for the excellent talks, and we have no ties, and it's a time for tea break, and we will come back. We will come back. Yeah, Dr. Lemon. Yeah.
And my personal experience in the management of one of my patients with very strong, thick motoric of the head and neck, like the case in the video clip of the lady. And at that time, I have to use a combination of high dose haloperidol plus baclofen and even plus diazepam too. And in this case, it worked. This combination did work. But very strong movement, and you can hear the noise. Yeah.
That combination that you mentioned, it was proposed by David Marsden, and he used it quite a lot during the old days, and it's called Marsden's cocktail. So basically, if you knock the patient down a bit, the hyperkinesia subside. And I think that is probably what we need to do at that time. But I believe that the DBS is very promising in that type of the malignant pigs.
We have one question from online, but that's for submit.
Yes, he asked that how to differentiate of post-anoxic myoclonus and myoclonic status epilepticus if no EEG confirmed. So I think I will answer it. If we don't have the EEG to confirm if the myoclonus come frequently, it has no cut point of how frequent, you can treat as the status epilepticus of myoclonus. So you treat as the status epilepticus because the electrical discharge also come from the cortical, like status epilepticus. Thank you for your attention.